Hello and welcome to this week's Health Tech Hour with me, Steve Roest. Each week we bring you the best news, views and interviews with the leaders, clinicians, founders, investors, journalists that are changing the face of the UK healthcare scene and the healthcare scene across the world. As regular listeners will know, I am a CEO and founder of a health tech venture myself, which is called PocDoc. PocDoc's flagship product, which is the Healthy Heart Check, allows anybody to get the equivalent of the NHS Health Check in just 9 minutes at home or anywhere. In fact, I actually do mine between meetings at work. It includes a full lipid panel, your NHS heart age, your risk of having cardiovascular disease, BMI, blood pressure, and a bunch of other things. If you are interested in that, then you can find it on the high street, and you can actually find it at the chain of shops that my guest today works at. So we'll get onto that in a second. Or you can head to pocdoc.co. So PocDoc.co for the Healthy Heart Check. And thank you as ever to PocDoc for all of the support for the show. Thank you, as I say every week, to the amazing team at UK Health Radio, Johan, Rafaela, the whole crew. They do an amazing job with the station. We absolutely love having the live platform with them. If you haven't checked out any other presenters, on the channel or on the station, please do so. There's some great content out there. Thank you. We love being here, and thank you for all of you who are listening live. Thank you if you're listening on any of the podcast channels. We're now getting downloads in over 50 countries every month, which is phenomenal. Thank you if you're watching us on YouTube, or if you are watching on my Instagram channel, where we take the best bits and we turn them into clips. If that's your bag and you want something a little bit shorter, then go to, I'm on @Steve Roest. So check me out on Instagram. Now, over the last episode that we did was a big one for the show, because it was actually the first time that we filmed and recorded live in a podcast studio with Dr. Melinda Rees, who is the CEO and CEO of Psyomics, and they are focused on how to clear the enormous backlog of mental health patients in the UK. I was kind of unaware. I mean, I knew that. I think most people are aware that there is a mental health crisis in the UK in terms of access to services. It's spoken regularly of in media channels, so I won't sort of go into too many details. I guess that was sort of the limit of my awareness. But she laid bare some of the statistics in it. In some regions, the waiting list equates to patients waiting over 20 years, which is insane. So her company Psyomics is really focused on that. She had some incredible insights around social media with children. Her view is that the effects are reversible, but you have to really engage with it. So I would really recommend that show if anyone's interested in mental health, social media, how this crisis is developing, and what actual practical positive steps can be taken. Then check it out. Episode 121. It's out now. Now, on to today's show. Today's show, we return to anyone that's been following the show or listening or has followed my journey or the journey of PocDoc will know that I have a real deep love for community pharmacy. Community pharmacy was the place where PocDoc started first. It was the place where we were welcomed first and supported first. There's a number of individuals, including my guest today, that took real time out of an unbelievably busy schedule to help us understand how to solve real needs in community pharmacy, both for pharmacists and for patients. And for that sort of time, which they didn't need to give us, I'll be forever grateful. Community pharmacy, as we had the show recently with Nick Kaye, who's the head of the National Pharmacy Association, has been undergoing some unbelievable shifts, partly driven by demographics, partly driven by supply side issues with the NHS, partly an overhang from COVID, all kinds of different things. But for most people listening, the pharmacy is the front door of care in the UK. And it really gives me great pleasure to welcome my guest today, Richard Harrison, who is the Healthcare Services Manager at Asda. And Asda were the first retail partner for PocDoc and our Healthy Heart Check in the UK. And we owe them a huge amount. And Richard himself personally, like I said, took time out of his busy schedule to help a small business understand how to adapt to a very hectic community pharmacy environment. So it's a real pleasure to have Richard on. He's a veteran of community pharmacy, really dialed into all of the issues, and I can't wait to get into this, and almost like a continuation of the discussion that we had earlier this year with Nick Kaye. So Richard, welcome to the show.
Lovely to be here. Thanks, David.
So let's start off. So let's go back a little bit. So how long have you been in and around community pharmacy for?
Longer than I care to admit, I think. Now, give or take a few weeks, about 20 years I've been
Wow.
in community pharmacy. So I've been around the block a bit, I suppose. I've worked in independents, I've worked in regional multiples, and I obviously worked for Asda, and I've worked with Asda since 2010. Kind of found a home here, really. So.
Okay. And so what was your journey into the wonderful world of community pharmacy like?
So my background is healthcare. My family has always in the last couple of generations, always been very healthcare related. My dad was a dentist, dental surgeon. My mum was a nurse. My brother's a chiropractor. Obviously, I'm a pharmacist by training. My wife's a pharmacist. So yeah,
Okay.
it's easy.
Was it organic, or was there a moment where you think, no, pharmacy's for me versus chiropractic or
Yeah.
doctoring, or I mean, I appreciate those aren't the actual real words, so I apologize.
So I think for me, when I was about 15, 16, I was looking at what I wanted to do. All I knew that I wanted to do was I just wanted to help people. That was it. And it's like, how do I do that? Now, my dad at the time didn't want me to go down the same path he went down, and I never really understood why, but there we go. And he was my role model. So therefore, you know what he said stood. So it's like, okay, that's fine. So I kind of went into pharmacy, and then as soon as I got into pharmacy and realised what it was all about, I kind of knew I picked the right choice. Even at university, it kind of just resonated that was this is the right call. You've made the right decision. Crack on. And
What can you remember? You know, not that I'm sure. You know, I don't want to. I don't know how long ago university was for you, so we won't go into that. But what were the bits that made it click? Can you remember? Was there like a few bits where you were like, "Oh, this is for me," when you did a particular course or particular module, or like, how did it click?
I think it clicked about halfway through the degree course, and you're following it through, and then there wasn't one particular moment. It's quite boring, really. It's more the fact that it's several little pieces that you start piecing together. You do some modules on toxicology, and then you see it in practice, in pharmacy practice. Then you see it in the clinic, pharmaceutics, and all those kind of little bits. You see it out in the community. And you kind of build a picture, and you build that picture and go, this all makes sense. This all makes sense. This is all good, and this is exactly where I want to go. Yeah.
And I think the one of the things that was really was hit home to me, or hit home when I was talking to Nick, and I'd love to get your thoughts on it. Sort of touches on what you said there. The amount of training that a pharmacist has to have is actually really quite high and extremely technical and very medical. It's not like just banging out packs of ibuprofen. You know what I mean? There's actually, like, how long were you at uni for? Like, how long was that course and the training and the qualifications?
So it's a 5-year course, all in all. So when I did it, there was, I suppose it's still now, same now, you used to do 4 years at university and the year postgraduate. And again, it's very similar. You have a foundation year now, and I say 5 years of training before you're ever allowed to practice. And in that, it covers a whole range of things from minor illness and that kind of stuff. But I think a lot of people forget is that, yes, we see a prescription, but we have to clinically check every single one of those items as a safety net, because your GP knows what they're doing. Of course they do, but they're only human, and we are that safety net. And when we are dispensing all those prescriptions and you see the queue and you're the patient in the queue, it's
Yeah.
not always known that we're doing all these checks and balances in the background just to keep you safe. And we know we probably will be safe, but you know what? We need to make sure.
Like, let's dig into that. So give us an example of one check or balance that the general public may not be aware of that you do, for example. Like let's I love, this is why I love the show.
Yeah. So again, very, very basic one from back in my days when I was a pharmacist, wasn't that long ago. I still practice.
Yeah.
Is regular patient on a blood thinner, and then they need some antibiotics. So therefore, they were given some antibiotics, and you look at the antibiotics and you go, hang on a minute. This particular antibiotic affects liver enzymes. That affects this drug. So, okay, let's just give the GP a call and
Interesting.
give the GP a call. And in this circumstance, again, GP was already aware, which is great. And then we went through the pathway and said, okay, what else could we give? And we ruled out several, looking at the history together as a team, ruled out that, okay, that doesn't work, that doesn't work, that doesn't, you know what, I agree, that is probably the right thing. But what do we do now? Because that's going to affect their blood thinning, and we need to think of the next steps. And it's like, yeah, you're dead right. Okay, and here's the plan. Can you tell the patient we're going to do this, this, and this? And so we work as a multidisciplinary team to make sure that that patient is safe and right. And the GP probably already told that patient that at the time, but we've got to you've got to remember that patient's been given an awful lot of information.
Yeah.
Probably only absorbs, the same as all of us, we absorb some of it. In the back of their mind, they're sitting there thinking, oh, no, I'm not very well. I've got antibiotics now. How am I going to take those again? And you forget all that other information.
Yeah. And also, like, you can't, things like side effects or
Exactly.
interfering substances and things like that I can't believe that that's the responsibility of the patient to sort of figure out, right? That sort of has to
Yeah,
be the clinician, because how would we know? How would I know?
exactly. And that is why we've got, the prescriber who again does a fantastic job of covering that, but they only have so long to do it.
Mm.
And then, of course, it comes to the pharmacist. When you hand out that medicine, you have another little conversation with it. And there's now a new service, been that outrageous. There is a service in the NHS called New Medicine Service. So if you are on a medicine, on a certain category of medicine, and there's 13 categories, and these are meaty categories, things like blood pressure, asthma,
Okay.
diabetes,
Big
big categories,
categories.
Parkinson's, glaucoma, those kind of things. We will then, obviously with your permission, either contact you either via face-to-face or via a telephone call a week later. We've already spoken to you when you've picked up your medicine, and then we'll phone a week later just to check how you're getting on. Are you taking it? What side effects are you seeing? And if they are seeing side effects, are they manageable? I mean, if you're taking a certain blood pressure tablet, you take it in the morning, it's making you go wobbly. Well, take it in the evening, because that will be that kind of first dose hypertension will wear off. Give it a few weeks, you'll be fine anyway. But
Okay.
easy consultation and healthy lifestyle advice.
And so but when did the new medicine service launch? How long has that been?
A long time ago. We're talking probably 2013,
Oh, it's been around for that's a
over
good
a
chunk of time.
decade.
Yeah.
And it's a mainstay. It's part and parcel of what we do. Realistically, what we do anyway at the counter is just that we're giving that patient that extra support on top of what they're already getting from their GP, because the GP will probably have put a call in within a month afterwards. The new medicine service is the bit in between to just check, how are you getting on? Are you okay? And it's like, and things there are occasions where you pick something up and go, that really isn't right. Okay, let's just stop here. We need you to go back to your GP now to resolve this, because something odd's going on.
So like
Doesn't happen very often, but
so when
occasionally it's there as that safe safety net.
let's talk about this. So because you said you started your career as in independence,
Yes.
independent pharmacies. So a given independent pharmacy of some normal size or sort of reach,
Yeah.
how many of those new medicine calls might be being made per week or per month? Like, because that strikes me that could be quite a lot of phone calls
It is.
potentially.
And there is a cap the NHS have put on it, so it helps us to limit the number that we can do. And obviously, we can do as many as we have capacity to do.
Yeah,
Again, we could reach thousands, but we don't.
that's what I mean, right?
It's based on the number of items. The limits that have been set in for NMS, and it's quite rightly so, is based on the number of items you dispense. So the more items you dispense, the more you can do.
That makes sense.
Yeah,
That
so
makes
makes
sense.
perfect sense. So
Yeah.
if you're the average pharmacy doing around about, I don't know, 5,000, 6,000 items, for example, that's items, not prescriptions,
Mm.
then you could do up to 120 phone calls. So, but
Per,
that
per
could,
month.
because there's two potential calls for every new medicine service. So you get the initial call. So you've spoken to the patient the week after, check how you're getting on.
Mm,
And then with their consent, you phone them again 2 weeks later. Again, just a touch point.
mm,
Everything's still okay? Are you still taking it? Any new side effects? How you get? I gave you some advice 2 weeks ago. Has it helped?
mm.
All those kind of questions. And there's also the clinical pieces behind it as well. So,
And,
say,
and back in the day when they introduced that thing, were there people that were sort of arguing that that shouldn't happen, like we shouldn't be doing this, or was it like was it universally like no, this is a really good thing? I'm just curious.
realistically, I don't remember. Again, it was a while ago.
Yeah, yeah, yeah.
Um,
I'm just
but
interested.
I don't remember any real noise at all from people saying we shouldn't be doing this
Right,
because it's obvious.
right.
It's obvious. And for me, obviously, I went into pharmacy to help people.
Yep.
This is exactly what I wanted to do. Is that, and this is why I came into services later on,
Mm.
is because you know what I want to be providing services and being able to empower our teams to provide services to help the communities we serve.
Well, let's pick up on that thread. So, at what point in your journey through community pharmacy did services start to be made a noise about? That doesn't make sense. At what point did services? Because now there's a really big drive towards services in lots of different ways. But was that a slow build, or was there at some point where suddenly something happened and it suddenly
Yeah,
became the hot topic?
yeah. So again, it's all based on the pharmacy contract that we had at the time.
Mm.
So up to about now, again, Nick, you guys had on before, has probably knows more about this than I do, but because it's obviously before my time. But when I qualified, there was very little in the way of pharmacy services, and then they slowly started to build. The new medicine service landed, then flu, and you can deliver flu in pharmacy.
Mm.
And then around just before COVID, you started seeing other services just start to appear. And then COVID hit,
Yep.
and then we really delivered as a
Mm.
profession. We were there for patients, and we were still there. We were walkable. We could walk in to see us still, and we were delivering flu, and a lot of my counterparts, including myself, were delivering COVID vaccines as well. And then since then, other services built from there. So you saw blood pressure landing in 2021. And now there's other services like the new contraception service that landed too. So any person who wants regular contraception in England can get it.
Hmm.
And then pharmacy first as well.
Yep.
So
So so was that change in the contract, do you feel like what was the driving force for those changes coming from within the pharmacy industry, or was it coming from the NHS, or was it coming from the government, like, or is it a bit of everything, or patients as well potentially?
I think it's a bit of everything. My personal opinion on this is the fact that there is a challenge within the NHS currently because there's more people requiring looking after than there are appointments,
Mm.
and that's not a fault of the NHS. We are living longer. We have more complex condition states. We need more care,
Yep.
and so we have to. How do we cut the cloth accordingly?
Mm.
And so I think that's part of it. And of course, for pharmacists for years, what we've been saying, and our negotiators have been saying, we can do more.
Yeah.
Give us more. And
Yeah.
here it is. Here's the start of it. Just
Yeah.
starting to filter through now.
Yeah, I mean my experience from working, obviously not in community pharmacy, but with community pharmacy and pharmacists and pharmacy teams, in whether it's a NHS funded pharmacy as an adjunct to the GP surgery, or whether it's a independent, or now obviously with Asda as a large multiple, um, which is great. You know, what's clear to me is that you're dealing with teams that are extremely highly trained and extremely close to the needs of the community that they are based in, and um, able to actually deliver community-based care, which is one of the big shifts that the government wants to deliver on, or the NHS wants to deliver on. And so I guess it's no surprise to me that there's more impetus around leveraging and using these highly qualified individuals and teams to the fullest of their capacity.
Yes, I agree. And I think, and it's only growing now, I say, from until sort of last year, only pharmacists could deliver a lot of these services.
Mm.
Now pharmacists and technicians can deliver some of these other services. And now things like the hypertension case finding service, or blood pressure services, which is a fantastic service.
Yes.
Now our colleagues can deliver. And so our colleagues can deliver, and obviously have to have a clinician, a pharmacist behind there to intervene if necessary. But we can identify now patients who have potentially high blood pressure, because you've got to remember, any normal blood pressure you take is a snapshot of what's happening right
Yeah.
at that point. It doesn't give you any indication of what happened half an hour before. Have they had a coffee? Have they had a
Yeah.
fight with somebody?
Yeah.
So, but
They walk up some stairs.
exactly. They just run in. Can I have a blood pressure done? That's probably not the right time to do that. But yeah, but it gives you a snapshot. And if it does come up as, well, that might be hypertensive, we can now fit an ambulatory blood pressure monitor, which is that monitor that goes off every half hour and is very frustrating, keeps you up at night.
Yeah.
But we can fit that in the pharmacy now, and
Well,
then which gives you a much more averaged value of exactly
yeah.
what's going on.
The blood pressure hypertension case finding is widely
Yeah.
regarded as a resounding success of
Yes.
a nationally funded, locally delivered service. I believe. I mean, I think it's one of the shining examples, isn't it, of that type of
Yes,
thing?
I agree. And I think it's exactly, again, it's really easy to access because it's in community pharmacy. And you've got, what, 10,000 odd pharmacies in England, give or take. And they're in places where people are, where our communities are. I mean, I know, well, I work for Asda, and we're in a supermarket. So, of course, you're going to get your shot. You can get your blood
Yeah.
pressure done at the same time if you want to.
Mm-hmm.
Or you're on the high street, and you know what, you're in that community, you're in that street, rather than quite some distance away, which means you've got to travel to get there.
Yeah. We are going to stop for our first commercial break of today's show. So we will be back after 2 minutes with my guest on today's show, Richard Harrison, who is a community pharmacy veteran and the healthcare service manager at Asda, and a thoroughly supportive individual for any innovations in community pharmacy. So we'll be back after a short break. Hello and welcome back to this week's Health Tech Hour with me, Steve Roest, and my guest today, Richard Harrison, Healthcare Services Manager at Asda. So, Richard, let's switch it up a little bit. We were just talking about the blood pressure hypertension case finding service, which is a really long technical way of saying you can go into pretty much any pharmacy and get your blood pressure done for free in 15 minutes. Which everyone listening should do. If you've not already done, just go and do
I
it.
will caveat it, it's for patients over the age of 40 who aren't already classed as hypertensive. I'll just add that
That's
in.
very helpful. So
Bombarded.
that is a very good caveat. So over 40s, not already on medication, can go and get their blood pressure checked at pretty much any pharmacy. Yeah, good shout. There you go. You see, look, there's that pharmacy training, right? There
Straight
it
in
is.
there.
Right there. Yeah, just straight on it. So let's and actually PocDoc's being used, the healthy heart check's actually being used alongside or as part of that hypertension case finding service. So blood pressure and full lipid profile and cardiovascular risk all in the same sort of 10-minute window, which is super exciting. And we can come back to that later in the show. But I want to pick up on a couple of other things. So the first thing is, when Nick came on, obviously he was deep in this sort of political action, I guess, advocating on behalf of community pharmacy with the government, with the NHS around the new contract. And there was lots of things happening and lots of headlines and things like that. So you mentioned in the preparation before the show that contract now has been finalized. So what's the upshot? Where give us an update.
Yeah, so the contract was finalised and it was announced on the 31st of March.
Oh wow! So like Friday.
So yeah, so 31st of March, not May.
March. My bad. Sorry.
That's all good. It's all good.
Yeah.
It was announced a couple of months back, and it shows a real vote of confidence, in my mind anyway. It shows a real vote of confidence in community pharmacy.
Okay.
It shows it's a really good step to. I've listened to Nick's thing, and it's a really, really good show, and I agree with a lot of what he said. But I do think it's a real positive step, and it's a good step. There is probably more we need to do, but everybody on both sides agrees that this is a work in progress.
Okay. And so what are some of the real sort of positive highlights of it? for you?
So from this, I know Nick talked about sort of dispensing and how the dispensing process worked. Some of that is that they have leveled the funding a little bit, so that
Okay.
makes it a little bit, well enough, but a little bit
Mm.
better and more equitable to dispense items. So therefore, we can run our pharmacies more safely and be able to basically fund it
Yeah, because
without.
when Nick came on, obviously, I'm not sure who listening has listened to that show, but one of the points Nick was making around community pharmacy was that in effect, the volume of things you're dispensing has effectively doubled or tripled, doubled, tripled, massively
Yeah,
increased.
it's gone mad
With this,
now, and up to when he spoke, the operating margin which he mentioned was 800 million. So basically, that's the maximum amount we were allowed to make as a professional body.
as a whole industry, right? That's
The whole industry,
there's a
800
capped
million.
pot. This was another thing that he blew my mind with. It's a capped pot, so
Yeah,
you divided equally or pro rata based on what gets dispensed at each pharmacy, right?
pretty much. Yeah. So there's a lot of other bits in it, but yeah, yeah. So for the dispensing margin, you're allowed to make that. That has been increased. So that's been increased quite substantially. It's gone from 800 million to 900.
Oh, that's nice.
That's really positive step because
Yeah,
again, it allows us to be able to make it work. When Nick was talking, we were seeing pharmacies close.
yeah.
Um, as I said earlier, we're not out of the woods yet, and there is
Mm.
work to do, but it's so much better than we were 2 months ago.
That's great.
We just got to work with it
Yeah.
and crack on.
And what was some of the other things that he was mentioning were around sort of being asked to do more for not more investment. And so, is
Yes.
there anything in there that addresses sort of like this thing we were talking about before the break, where it's pretty clear that the direction of travel or a direction of travel is to move more services or provision, if you like, into community pharmacy. Was it have there been any announcements around that or anything clarified around that?
Yes, there have been. They have um, provided a provision to help fund things like Pharmacy First. So
Okay.
that doesn't eat into the normal pot, it's a separate pot. That's my understanding of it.
Hmm.
And other primary care recovery bits, but that doesn't necessarily affect pharmacy directly. But say for Pharmacy First, for example, I know you mentioned it in Nick's interview. That is, you know what? Again, that is why a lot of pharmacists came into pharmacy.
Mm.
Before that point, I'm guilty of it myself. The number of times you're at the counter, someone wants to come and see you, they'll show you an insect bite, for example,
Hmm.
and you look at it and go, yeah, that's red, that's inflamed, that's swollen, you've had it a couple of days, you can see it's obviously a bite, and it's like, you probably need to go and get that seen because the back of my head, that looks infected, you
Mm.
probably need to go and get that looked at. I probably know what antibiotic you get, but I can't help
Mm.
you. And
Wow, that must be so frustrating.
very,
Like
very,
really,
very
really
frustrating.
frustrating.
I mean, I was quite lucky because there are locally commissioned services that are commissioned for need. Now, thankfully, I was working when I was before I came into this role. I was working in an area that was quite progressive and actually created locally commissioned services that allowed us to address those kind of needs.
Yeah.
But for the rest of the nation, they couldn't do that, and
Mm.
it's extremely frustrating because you'd see the patient, you'd known them for years. They
Yeah.
come in with, using this example of this bite,
Mm.
send them back to the GP. They have to try and get an appointment with a clinician, which obviously they are stretched as well.
Yeah.
And they come back with the exact same antibiotic you back of your mind knew they were going to get. But
That's amazing.
that was the way it was. And
Yeah.
you just had to just grin and bear it because that's the way it was. Pharmacy First changed that. It gave us more tools in the toolbox.
Mm.
So a patient comes in and saying, you know what, my child's got an earache, and it's like, what do I do? I can't get an appointment for GP for 2 or 3 days, and it's like,
Yeah.
they're suffering now. It's like, no problem. It's like, we'll see you. It's like,
Yeah.
you may have to give me half an hour to get some headspace to come and see you, and I'll come and see you.
Yeah.
Put in the consultation room, use an otoscope, because I say all pharmacists should be trained on otoscope usage now. And
That's the ear
Oh,
thing. That's the ear.
that's
That's
the
the
ear
ear.
thing they
The
stick you
ear
in
that
and
they look
have a look at
through.
the
The
eardrum.
little magnifying glass thing with the little pokey out bit.
That's the one with the little light
Yeah.
on. Yes.
We love using technical language on this show, Richard.
Hey, there's nothing wrong with that. It's all good. It's all good. Um, but yeah, so we look at that, and if we identify acute otitis media, for example, we can give drops to help. Now, let's face it, a lot of earaches are self-limiting. You
Mm.
don't need any other medicine for it. It will clear on its own other than pain.
Yeah.
But there are cases where you do need antibiotics for it, or you do need further. You need to be looked at by a clinician. And this is what this service does, because we can have a look in your ear. If there's nothing wrong, it's just a bit red, that's fine. If it's a sign of acute otitis media, we can give drops, or if it's really serious in very specific circumstances, we can give antibiotics as part of a patient group direction. And then if it's more serious, it's a perforated eardrum, for example,
Yeah.
we're going to refer you on to the GP. And we're not just going to say, go to your GP, we're going to try and make the appointment for you.
Yeah.
We'll pick up the phone to the surgeon
So,
and say,
so when Pharmacy First came out, and again, I'm not sure if Pharmacy First is really like a consumer-facing brand. I don't think it
yeah,
is, or is it? Is it? Is it a thing?
Yeah, granted, this is England, because
Yeah,
Scotland and Wales have different variants on a thing.
of
I'm
course.
England here. So
Yeah. Why would we? Yeah. That's a whole
just to
separate.
add that little bit more complexity to it.
Yeah. Why not? Just add more complexity in. But so when this was being discussed, were people? I mean, because actually the way you explained it just then, the difference from before Pharmacy First to now is actually sort of conceptually quite huge. It's a huge step that's been taken by pharmacy, but also I guess by the GPs, the primary care people, to let that go as well.
It is, because it's trust. It's
Yeah.
trust that these clinicians know what they're doing. And as pharmacists, I like to think I know what I'm doing,
Yep.
but it's to obviously make sure that the clinicians have trust that we refer in. And now, the important thing to know with Pharmacy First is, because pharmacy is open longer hours than a GP surgery,
Mm-hmm.
you can now be referred directly into pharmacy for things such as Pharmacy First on a Saturday night at 7 o'clock.
And what does Pharmacy First cover? So is it UTI, urine infection?
So yeah, there are 7 conditions. So
Yeah.
test me here off the top of my head.
Okay. Let's
So,
see if we can get to all 7.
okay, so I should know this. If I know, I'm in trouble. So obviously UTIs.
Yeah,
So
urine
that's in
infection.
women aged between the ages 16 and 64.
Okay.
You have shingles. You have infected insect bites. You have impetigo. You have acute sore throat.
Okay.
You have acute otitis media, which is talked about the earache thing there.
Yeah.
And there's one more which I can't think what it is now, because
Is it contraception or is that separate?
No, contraception is completely separate, and I'm going to kick myself. But there
Okay. Well, I tell you what we can do, because we're going to go for a break in a minute. You can have a little Google around what the
No, I don't need to Google it. I just need to sit there and go, what was it?
What is it?
If it's off air, I'll be fine.
I just and how does that sort of stuff play out in the context of a supermarket pharmacy chain? As in, is it the same? It's just it just operates like a pharmacy in a supermarket, or is there anything that's unique about pharmacies and supermarkets?
So the main thing that's unique about supermarket pharmacy is access.
Okay,
There's plenty of parking.
that's a great
So,
shout.
so you never have to fix it. You know what? You can
Yeah.
actually park, and if you need disabled parking, there is disabled parking. It's simple stuff.
Yeah,
Yeah,
that
there's
makes
good
sense.
lighting and all that kind of stuff. But when you get into the pharmacy, they're open extended hours. They're open at weekends, Sundays, bank holidays. They're open later than 5 or 6 o'clock. They're usually open till at least 8 o'clock. Well, I'm talking supermarket pharmacies here.
Yeah.
And you will get the same treatment and the same service as you would do with a pharmacy opening 9 till 6. But it's more the time that suits you.
And when did were there always pharmacies and supermarkets? No, that happened at some point.
No, that happened some time ago as part of well, we've had pharmacies going for 25, 30
25 years,
years.
yeah, long time.
Probably longer.
Yeah.
But They changed code of entry a long time ago, which basically meant you could open 100-hour pharmacies. So prior to that, you can't open a pharmacy. You
Okay.
have to be commissioned by the NHS to open the pharmacy and given a contract by the NHS.
Is that serious?
Yeah, yeah.
So you can't just basically say, oh, I'm gonna open Steve and Richard's pharmacy and we open and we can't do that.
No, not at all. So
Really? That's interesting.
you'd have to put a request in to the NHS and say, I'm not an expert on this.
Sure. No, this is a whole new area. I never knew this.
But to say, and so they'd have to go through a panel for market entry. And my understanding is that it either gets passed or it gets failed. And if it gets passed, and it's usually passed if there is a need in the locality. There is no point putting an extra pharmacy on the high street if it's going to offer it's not going to offer any value,
Right.
because it costs money. It costs the taxpayer to obviously pay prescriptions and everything else. And you know what?
Yeah. And do they take a view a little bit? I don't know how they would do this, but it's sort of like, look, we actually don't really need more competition because all we're doing is just sort of dividing the pot between more pharmacies. So actually the population here is very well served because we have a Boots, a Superdrug, an independent all within a square mile. Or is it more around the actual clinical, need?
I can't answer that.
Oh, right, okay.
That's more a political piece. I don't political and an NHS piece other than mine.
Okay.
I think for me as a pharmacist, my comment would be, do we have enough capacity in that area to support that locality, to support the needs of those patients?
Yeah.
And different areas will have different needs depending on whether they're underserved or whatever it is.
Okay.
Yeah.
And what's the difference? And I'm sure lots of people listening have noticed this, but there's now quite a lot across the country of pharmacies in a GP surgery.
Yes.
And has that always been the case? I'm trying to understand if that's been the case or that was a new thing, and why is it a good thing? In which case it should be in more places, or is it just a very local decision? Or what's your take on this whole thing?
So that is a decision for the GP surgery and the pharmacy.
Okay.
There is no reason why you can't do that.
Yeah.
But there's no reason why you can't either.
Okay. So it's just a complete. Yeah. Okay. Interesting. That's really interesting. I just think it's a really vibrant sector that actually has really lots of really smart, talented people in it trying to deliver healthcare across goodness knows how many ranges of conditions and issues every single day. I just think it's really fascinating.
Yes, it is, and it's growing. And we know that we mentioned the contraception service that landed last year. So now any person who wants regular oral contraception can go into a pharmacy and get it without having to make an appointment with a GP.
And that's so progressive. I think. I mean, I'm not an expert in oral contraception at all. But I don't know if there's any other countries that are like that you can just walk in and get that in Europe and things like that. I don't know. I feel sometimes we don't give ourselves enough credit for the strides that we have made.
I agree.
Who are we comparing ourselves to?
I think, well,
I don't know. That wasn't a trick question. So carry on. Sorry, you were going to say you agree.
Yeah, I agree. I think it is very progressive. I think the progressive, but when I say that as the UK, because for England, we looked in 2023, I think it was, for the contraception service. There was variants of this already live in other nations, and the devolved nations. Wales and ahead, that was there beforehand. And we tend to find that one nation will come up with a fantastic idea, and it will start it there. And then you tend to see that parts of that feed off to other bits and say, that was a really good idea, but I'm going to add something different to it. See it with, say, the Common Ailment Service in Wales, which is the Common Ailment Service and Pharmacy First in Scotland, which is different to Pharmacy First in England, based on why make it simple?
Why make it simple?
Which is based on minor illness. And again, the same consultation and being able to provide medication to patients. And for those medicines, those services started off as locally commissioned so that provide medicines that you can get over the counter, but to serve those areas that can't afford it, basically, and be able so that regardless of your status, you can get medicines without having to pay that fee that you'd have to pay
Makes
at the
sense.
pharmacy for under certain conditions. Pharmacy first is very different. And you
Yeah,
tend to see now that those other bits of services are progressing as well. So you tend to
right.
find, so I think, to be fair, Scotland did it first and Wales did it first, but they add in other bits like UTIs, for example, have been in the Scottish model for a while. UTIs have come now in the Welsh model as well. So
Okay.
test and treat is now in the Wales model. As of the 1st of June, that is now mandatory as part of
What's test and treat? I know test and treat from a COVID. What's it in this
sore
instance?
throat tests and treat. So
Okay.
basically, you're checking for a sore throat. You can do a swab as well for a sore throat.
And does the swab go to a lab or is it a point of care?
And so
Good for.
again, very similar to acute sore throat service in England, but
Okay.
similar and different. So,
Okay.
but yeah,
Interesting. Well, look, we have to go for our last commercial break of this show, and it's just I just love the area of community pharmacy and sort of digging into this stuff. Carry on.
sinusitis. That was
What's
the
that? Si-
sinusitis. I knew it
Sinusitis
would
was the
come to.
seventh condition. Good. Okay, good to know. So we will be back with the last part of today's show with my guest today, the Health Services Manager from Asda or of Asda, Richard Harrison. We'll be right back after this short break. Hello and welcome back to the final part of this week's Health Tech Hour with me, Steve Roest, and my guest today, Richard Harrison, who is the Health Services Manager for Asda and a long-time community pharmacy leader. So, Richard, before the show, you mentioned that you wanted to touch on the area of meningitis and community pharmacy. I believe. So I'm not sure exactly what you wanted to touch on, but that's an area which I'm not really familiar with, but I know it affects millions of people across the world. So why don't we dig into that?
Yeah, that's fine. So it's just to raise awareness more than anything else. So we have gone on a bit of a personal mission for meningitis. Now we've had a meningitis. Well, first things first, there are two main different types of vaccine jab. There
Okay.
is an ECWY jab, and then there is a B course of injections. Basic rule for most people is that ACWI, if you're going on holiday to certain areas of the world, so there's normally a band that goes around the world, especially things like Africa, Central Africa, and certain parts of Southeast Asia. And it's known as the meningitis band, basically. And if you go into those areas, it's recommended that you get an ACWI vaccine before you travel because it's prominent in that area. It's also a requirement if you are going for pilgrimage to a Hajj or Umrah. You
Okay.
need a certificate to say, yes, I've had it in the last 3 to 5 years. And so we've provided that for years, and it's been very well received.
Hmm.
However, about 2 years ago, I can't believe it's been 2 years, we had one of our central team, one of our area team, contract meningitis, went on holiday and passed away, sadly.
Oh, that's terrible.
So we decided, once the dust had settled from that, and we'd sort of picked ourselves up after the initial shock, we reached out to Charity Meningitis Now. And we've been working with them for the last 18 months to raise awareness for this horrible condition. And through those conversations, we realised that whilst ACWY is endemic in England and the UK, and there are vaccines available for it in the UK, as is at B, we don't vaccinate for B past, I think it's about age of 14, I think they get the vaccine. Again, I'm not
Okay.
expert on this piece. They are. Go to them if you want any more.
Sure.
But however, the highest concentration of people who contract B are those people going to university. And the reason for that
Okay.
is because the vaccine we believe the vaccine tends to wane, but obviously after about 4 or 5 years, which is exactly when these people are going off to university.
So just back up a second. So when you say we, you mean Asda?
So,
Presume.
as in just the general, so from
Ah,
meningitis, and for meningitis, just the information for meningitis,
okay.
we understand. I think the
Ah,
best way to put it
okay.
is the vaccine. We believe the vaccine tends to wane because we see more infections from meningitis at university than anywhere else. And they're the main cohort. Obviously, there's a whole range of them, but that's the main cohort.
Okay.
And
So people get vaccinated at school for meningitis. What did you call it? ACW.
So ACWY, and you get vaccinated at B for, I can't remember the schedule off the top of my head, but about 14 they get their last dose. And
Okay, but they target two different strains of meningitis.
exactly. So ACWY covers the 4 strains at ACW1.
Oh, that makes sense. ACWY.
Yeah.
Okay, got
So
it.
they're endemic as well in the UK, and
Okay.
there is a treatment program for it. And I recently read there is a catch-up program as well, which I've read this week as well, for patients who missed their last dose. They can go and get them if they're sort of the early 20s, I believe.
Okay.
But B, again, the highest concentration of people who catch B are at university, and we currently do not have a vaccination program for that cohort of patients.
We don't have a meningitis B vaccination program for people after 15 years old or whatever.
Well, so when you've had the jab, it'll last for several years.
Okay.
But obviously, that's when they start to wane off. We're seeing more people getting the jab, but as part of the normal childhood immunisation program.
Interesting.
Then it starts to wane.
Right.
And we believe it starts to wane because you start seeing more infections because they're now all together at university or college careers, and you're more likely to see at that point.
Okay.
So for us, we worked very closely with them, and we spoke to partners, and we announced it at sort of Pharmacy in Practice in Scotland in March. And we spoke to our key stakeholders, our suppliers, supply network, everything else. So we now offer a meningitis B course of vaccines. Because it's not a single jab, unlike ACWY, where you can have a single jab and you're done for 3 to 5 years. Crack on.
Okay.
B is a course of vaccinations of at least 2 vaccines over a period of months.
Okay.
And you can get them, and but you can get them privately, and they're expensive. And we offer ours. We made a point of saying, well, it's the right thing to do. We're going to offer ours cheaper than everybody else,
right?
Because it's the right thing to do, and it's still expensive.
Okay. How much is it?
Would I like to offer it cheaper? Yes, I would. Can I? No, I can't.
How expensive? What are we talking about?
So that course of vaccine is it's £179 for those 2 doses.
Oh, okay. Okay.
So it's expensive.
I mean, yeah, it's a reasonable sum.
It is a reasonable sum.
And so what?
I would urge any parent, pay for it.
Yeah,
either with us or somewhere else who work. You know what? Doesn't matter. 10, 20 quid. Just get it.
Yeah. And so to go on pilgrimage, to go on Hajj, do you need ACWY?
ACWY.
You don't need B.
No, don't need B. ACWY, you need a certificate, which you should get when you get vaccinated. You should be given a certificate, which you must keep very safe.
And so what's the NHS's view around meningitis B? What's the current sort of standard of care? What does that say?
I'm not the expert on that piece.
No. I'm not trying to put you on the spot. I'm just kind of interested, right? What do you? Yeah.
I know there are a lot of conversations going on in the background with this.
Yeah.
I'm not privy to them.
No,
but I know they're happening.
Right.
And yeah.
Because I think this is a good example potentially of how the private sector has stepped into a gap, rightly or wrongly, at a different range of price points to solve what is clearly a need, because there's clearly people being infected and unfortunately really sadly dying. And so there's obviously a need, and I'm obviously not an expert, and neither are you in this space, but it would be really interesting to try and understand, because there must be some kind of clinical pathway in the NHS already about meningitis B. It won't just be a black hole. It'll say, well, these do this, don't do this, and follow these rules and don't follow those rules. Just be super interesting to see what that is.
I agree.
Yeah,
I agree, and I know they will have it. I'm not privy to it, so I can't.
No, sure. And it reminds me a little bit, completely different, obviously, but around the weight loss piece as well, where there's a big discussion prompted by weight loss around the role of private providers versus the NHS in that space, and that must be something that's been hugely disruptive, potentially in a positive way, for community pharmacy over the last few years.
I think so. I think with all, you tend to find that community farmers tend to lead the way. To your point earlier, they tend to find gaps where you need to provide something else because there's not a commissioning piece there at that time.
Mm.
They fill the gap. So again, other bits would be sort of, um, let's face it. Again, we'll say we'll stick with Asda because I know Asda.
Sure.
The pharmacy first earache part of it, it
Yep.
only works for 17. And there's a very good reason why it only runs to 17 in the NHS, because 80% plus of patients who get earache are under that age. So that's
Yep.
the goal. We saw as a business that we had an awful lot of patients over that age who wanted to be treated.
Mm.
So we now offer an adult earache service, which is exactly the same as the NHS service under 18. However, it's private, so you've got to pay for it. But at least I'm offering it to everybody.
Yeah, I think that's I think that's a really interesting debate, and I can only see it increasing in frequency and probably volume as we progress in the next few years around the interplay between what gets paid for by who and this spectrum across every condition around where does the line sit around who specifically, like under 18s, over 60s, over 40s, under 74s, on medication, off medication, what constellation is funded by the government, effectively by the NHS, and what isn't, and that interplay between those things, I think it's going to be fascinating over the next few years.
I agree. And I wouldn't want to be making those decisions.
No, it's super hard.
And they can't win.
No,
You know
no.
what? I wish them all the luck in the world.
Yeah, the tent isn't big enough for everybody, and unfortunately, there has to be a line drawn somewhere. So we're in the last couple of minutes of the show, and I always ask everybody this during the very difficult times, which I'm sure you've been through, whether it was COVID and it was brutal being in community pharmacy or whatever it was, earlier in your career getting going. What have been the mottos that you have used or relied on, or you've used with your team to get you through those kind of tough times that you think sharing it with the world and anyone listening might give them a boost in a tough time?
You know what? For me, I kind of, it sounds a bit trite that when you say it, but I actually have it at my desk behind my screen.
Yes.
And I coined it during COVID because I say I was in the community when it was challenging.
Really
And
difficult.
the comment was, you know what, no matter what, it will be fine. And it's just that it's very simple, but
Mm.
you know what, it works because you know what, doesn't matter, you'll be fine. Whatever happens, however the cards fall, you'll pick yourself up, you'll go again. It's fine.
I think that's great. I think that's like quite stoic, you know. It's like, look, there's going to be obstacles, there's going to be problems. We'll do what we can do, and then we'll see where the chips fall. But it's going to be okay.
Exactly. And realistically, I say in this role, I tend to ask myself that question because we're all subject to self-censoring. Will that work? I'm not sure whether I'm not sure what that could do. Realistically, how do you know if you're going to try?
Yeah.
So
Oh,
realistically, try it.
you you
Give it
you
a
you
go.
I mean, I like to think about it like Master Chefs. Like you got to get the dish on the pass. Okay, even your beurre blanc or whatever might be off, but you got to get the dish up and see what happens.
Exactly. Yeah, give it a go. You know what? Chances are, whatever you're doing, whatever sphere, if it give it a go, you never know. It probably will go better than you think.
Brilliant.
Don't
Well, look,
self-censor.
on that note, Richard, thank you so much for coming on.
No problem. Thank you for having me.
Brilliant, and thank you to everyone for listening. We'll be back again next week with a new show. Thank you very much.